can start to get seated. Get started here in just a few seconds. All right, I hope everyone's enjoyed themselves thus far. I like to cap off each day with a rapid fire review. Again, more spaced learning, some more testing effect, and also hopefully do it in kind of a fun and more engaging fashion than many of you are probably accustomed to. Let's get started. Kind of a fun and unique game. Something I like to call a little ABSITE HQ. Not sure if anyone's familiar with the Trivia HQ. I think it's actually been discontinued since. But it was a fun mobile trivia game. Came on every day at 9 o'clock. Went through 12 or 15 trivia questions, and whoever was the final one standing at the end took home a grand prize. So I took a little ABSITE review twist on it. So here are the rules. Everyone's welcome to play, but only one of you will win. We're going to go through 100 rapid fire review questions. And we'll go through one sample one just to get you guys started here in a second. You'll have 12 seconds to choose the correct answer choice. Caveat here is only your first answer choice counts. Right? You can't change your answer. And the speed of your answer also factors into your overall score. Right? So if you answer it with 10 seconds remaining, you get 10 points. If you answer it with 1.5 seconds remaining on the clock, you only get 1.5 points. And we're going to keep kind of a cumulative score throughout these 100 questions. We'll check in after every 25 questions and see what our leaderboard stands. All right. It used to be 10. We bumped it up to 12 because there is a little bit of a lag on the feed. So these Christiana residents sitting here in the room may have a little bit of an advantage. So if you start creeping up towards the leaderboard, I'll congratulate you, but try to rein it back a bit. All right. Our final score or top score at the end will then be our ABSITE HQ champion. And they will receive a $250 Amazon gift card, which I'll email to you this evening. All right. Let's give it a try. Here's how it's going to look. What's the most effective and efficient way to prepare for ABSITE? You don't actually get any points for this one. I just want to get you familiar. And no hard feelings. You can answer however you want. All right. 90% of you would agree. All right. Again, there's a 12-second countdown timer. It's going to be a relatively brief question stem like this. You'll have 3 answer choices to choose from. I will give you brief pearls and learning points on each one. But we're going to try to move through this pretty quick. All right. Are we ready? Get those fingers ready and eyes on the screen. Most common ectopic tissue found in Meckel's diverticulum. Gastric, pancreatic, or neurogenic? Ding, ding, ding. Survey says gastric, correct. Number 2 would be pancreatic, neurogenic, just a complete distractor. Excellent. Next question. Used to mitigate the wound healing complications of glucocorticoids. Answer is vitamin A. Excellent. Fludrocortisone is going to be a mineral corticoid. Vitamin E, typically used for skin conditions, but you need high dose vitamin A. We're talking about 15 to 25,000 international units per day. Chromosome of the BRCA2 gene mutation. Let's see if we're paying attention to Dr. Dixon. BRCA2 is 13. Excellent. BRCA1 is going to be 17. Anyone in the audience know what chromosome 5 mutation is related to? FAP is going to be your most common. All right. Best initial treatment for SBC syndrome associated with squamous cell carcinoma of the lung. I talked about it. I hope you were listening. There's also a question in the chat about it. Excellent. Radiation. Good. Most important amino acid in the management of intestinal failure. Correct answer is Glutamine, excellent. The majority of you got it. Alanine related to gluconeogenesis. Leucine really isn't ever going to be a correct answer choice on your ABSITE. Intestinal failure, maybe like, what does that mean? Sometimes that's what ABSITE will do. They'll kind of just tweak the wording of a diagnosis, essentially shortcut syndrome. All right, electrolyte abnormality commonly associated with pyloric stenosis. Good, hypokalemia. We'll talk about that more tomorrow morning in our pediatric lecture, but excellent. All right, division of this nerve leads to weakened internal rotation and abduction of an ipsilateral arm. It's going to be your thoracodorsal. Good. Long thoracic is going to be your wing scapula. Axillary would cause an external rotation. Usually that's from what? A shoulder dislocation, right? First major branch of your internal carotid artery. Good. There's a little bit more variance here, but this was the tricky one. Internal carotid artery is going to be ophthalmic, right? Your superior thyroid artery would be your external carotid artery. I did tell you earlier, inferior thyroid artery is almost always the answer. This was the exception. All right, treatment of choice for a localized medullary thyroid cancer. So medullary thyroid cancer spreads through the lymph nodes. You got to do a central lymph node dissection. If you have palpable nodes, right, then you would maybe do a modified radical neck dissection. We'll talk about that tomorrow in our endocrine lecture as well. Treatment for a 1 centimeter adenocarcinoma lesion at the tip of the appendix. Dope. Adenocarcinoma, right? That is a colon cancer and should be treated like a colon cancer, and you need your lymph nodes. A carcinoid at the tip of the appendix could be managed, right, with just an appendectomy. And again, similar to the ABSITE here, you saw over the last 10, 12 questions, majority you got it right, but these are the questions, those 25 to 15 questions that are going to make all the difference in terms of your ABSITE percentile. Respiratory quotient indicative of ketosis. Good, 0.7. 1.3 would be overfeeding or carbohydrate overload, also known as my diet over the last month. Make the diagnosis. Status post MVC, bilateral loss of upper extremity motor pain and temperature sensation, but the legs are spared. Don't break your phone. That is central cord syndrome. Anterior spinal syndrome, that's going to be infarction of the vascular supply, and that's usually after a kind of TVAR or a AAA repair. Brown's cord is a hemitransection. You'll never see that except in the textbook. Proteolytic enzyme commonly associated with formation of aortic aneurysm. This is the antibiotic associated. Sorry, I forgot to change that step. Cipro. Good. So fluoroquinolones also now associated with aortic aneurysm formation. The proteolytic enzyme is MMPs, right? Matrix metalloproteinases. The last one, Bactrim, that would be related to hyperkalemia and meropenem hepatotoxicity. Most common anaerobe bacteria found in the colon. Good, not as many fell for as I thought, right? Anaerobic Bacteroides. Talking about aerobic, then it would be Enterococcus. Strep bovis, what's that related to? Right, usually an underlying colon cancer. The other alternative would be Clostridium welchi. Phase of the cell cycle that is most sensitive to radiation. Right, that would be M phase. S phase is going to be your DNA synthesis. G1 is your longest phase, so the growth cycle, but M phase is your most sensitive to radiation. vitamin deficiency associated with encephalopathy and cardiomyopathy? Good. It's going to be B1, also known as thiamine. Right? B6 is folate. That you're going to have more of your proximal muscle weakness. B12, cobalamin. You're going to have more peripheral neuropathy there. Good. And we're going to do all these nutritional deficiencies tomorrow in our potpourri session. All right, nerve injury, most at risk during flap creation with this incision. Give me a hint, that's a mandible that they're working on. Good. Mouth asymmetry and the nerve at risk, marginal mandibular, excellent. Ipsilateral tongue deviation is going to be hypoglossal. You can occasionally get that just from retraction, but the biggest nerve at risk here is going to be your marginal mandibular. All right, make the diagnosis. Recent head injury, hyponatremic, normal urine output, and a low serum osmolality. Good, central SIIDH. Diabetes insipidus is going to have hypernatremia, so that's an easy one to rule out. You're also going to have polyuria with diabetes insipidus as well as cerebral salt wasting, right? Because water follows salt. In central SIIDH, you can have a normal or a low urine output. Soft tissue sarcoma associated with lymphatic spread of metastases. Rhabdomyosarcoma. Most of these are going to be hematogenious, right? But there's 5 specific sarcomas that spread through the lymphatics. Mnemonic being the SCARE acronym. Synovial, clear cell. I'm blanking on the A at the moment. Rhabdomyosarcoma and then epithelial. Good. All right, analgesic associated with the least mast cell release. Fentanyl. How is analgesics related to mast cell release causes vasodilation? Vasodilation causes hypotension, right? So another way of asking this question would be what analgesic or opioid is associated with the least hypotension, right? And that's going to be fentanyl. Morphine is going to be your biggest offender, to a lesser degree, dilaudid or hydromorphone, but the ideal would be fentanyl. Type of cell associated with wound contraction. Good. Oh, no one fell for it. So macrophages are the most important in terms of wound healing. I'll talk about that tomorrow. But myofibroblasts is what deals with your wound contraction. Test associated with diagnosis of echinococcal carcinomatosis. Good. Cassoni. Quantiferin is related to TB, right? And fibrillin 3 related to asbestos and mesothelioma. Most common type of gallbladder polyp. Dr. Sides isn't here anymore to debate me on this. It is cholesterol polyp, right? That is the most common gallbladder. Adenomas is the most common polyp in their GI tract otherwise. Esophagus, stomach, colon, etc. Calcium is your most common kidney stone, but gallbladder polyps are made up of cholesterol. Indication to discontinue antibiotic therapy for spontaneous bacterial peritonitis. Good, you guys actually know it. So I got tested on this on my written boards. I'd never seen it before. I was very angry at myself, and I vowed to never let anyone else ever get this question wrong. So good job. All right, most potent stimulator of pancreatic enzyme secretion. That's going to be CCK. Anaerokinase transitions trypsin to trypsinogen. Motilin just helps intestinal motility. All right, let's check in on our leaderboard and see where we stand. Dr. Kevin Sigley, 3 pretty strong lead, but not completely insurmountable. Let's see. All right, Christiana's got a PGY 2 on the board. Okay. Dr. Yellen, one of my residents, also on the board. All right, let's keep it up. Moving on. Next 25, pathogenesis attributed to the development of gastroschisis. It's going to be intrauterine rupture of the umbilical. Intrauterine vascular accident related to jejunal atresia or intestinal atresia. Good. And fibrillin genetic mutation. Marfan's, right? Has nothing to do. Gastroschisis. Good. All right. Main arterial supply for the stomach. Status post conduit for an Ivor-Lewis procedure. They love this question every 3 years. 90% got it. A right gastroepiploid. Most common location of colonic angiodysplasia. Angiodysplasia, also a fancy name for ABM, and that's going to be on your right side or cecum. Autosomal recessive bleeding disorder associated with the absence of von Willebrand factor and low factor VIII levels. Type 3, good. Majority got it. So type 1 von Willebrand is a quantitative defect. You have low von Willebrand factor. Type 2 is a qualitative defect. The receptors are off. And type 3 is a complete absence. The other kicker with type 3 is it's the only one that's autosomal recessive. All right, most common CD117 point mutation associated with imatinib or Gleevec sensitivity in GIST tumors. Dr. Bennett quickly went over it, and there was a question in the chat about the good exon 11. This has to do with your c-KIT mutations. Not every GIST tumor is going to be c-KIT positive, although a majority are. Exon 11 is the most common. Exon 9 means that your sensitivity to imatinib or Gleevec is low. So you actually have to double your dose and usually double your duration. And exon 17 means it's not going to work. Right? These are negative. All right, type of thyroid cancer most often associated with bone metastases. Nope. It is follicular. So anaplastic is aggressive, local, very poor prognosis. Remember, medullary thyroid cancer we talked about is lymph node spread, right? That's why you have to do a central lymph node dissection when you do your total thyroidectomy. So follicular thyroid cancer is the one that's hematogenous and bony metastases. All right, antibiotic prescription requiring additional Coumadin to maintain that therapeutic range. Good, rifampin, phenytoin, and phenobarb are the three that I remember that will eventually kind of decrease your INR, and hence you'll need increased dose of Coumadin. Contraindicated induction agent for postpartum patient presenting with agalactorrhea. I talked about this in my talk. Oh. All right, not bad, 63%. Remember, we're talking about induction agents and something related to the adrenocortical system, right? That's etomidate until proven otherwise. Name the pharmacological treatment of choice for the most frequent viral infection status post-transplant. Good, got to work yourself backwards here, but the most frequent viral infection status post-transplant is CMV. Treatment of CMV is going to be ganciclovir. Make this diagnosis: 45-year-old female with a large left breast mass, smooth and leaf-like on exam, core biopsy with stromal epithelial elements and less than 5 mitoses. So I just realized that's the male symbol. Good, phalloides, excellent. All the same. Yeah. Guess you could be a male with it. Less likely, but vitamin deficiency most commonly associated with poor oral nutrition after a total abdominal colectomy. Vitamin K. So vitamin K is absorbed in the colon, right? This is why this is a big issue kind of in patients after total abdominoplectomy. Vitamin D usually absorbed in the terminal ileum. Vitamin A is more upstream, duodenum and jejunum. Progressive muscular weakness and ataxia associated with advanced stages of this type of lung cancer. I didn't mention it in my potpourri slides because it is extremely rare, but you guys got it anyway. Good. You remembered your first aid for USMLE book. This is going to be Lambert-Eaton syndrome and related to small cell lung cancer. Substrate precursor for nitric oxide mediated increase in cyclic GMP and subsequent vasodilatation. Good, arginine, which is why there's some theories that in septic patients, hypotensive patients, you want to limit the amount of arginine they're getting in their nutrients. There are special tube feeds out there. Hasn't really been shown to change any outcomes, but at least from a microbiology and physiologic standpoint, it makes sense. Number of new cases of a disease in a given population during a specific time period. It's also known as incidence. Good. Maybe I could skip over the whole stats lecture. Paralytic with metabolic elimination by Hoffman degradation. Good. Cystatric, remember, Nimbex, pancreatin is going to be your longest acting one. Next step in management, a 60-year-old male with right upper quadrant pain and a 9mm gallbladder polyp. What do we want to do next? Good, lap chole. So it is less than 1 centimeter, only 9mm, but they're symptomatic. So if they're symptomatic or there's polyp end stones, you're supposed to take the gallbladder out, right? Because those stones can cause more irritation, which is anitis, for cancer development and gallbladder carcinoma. So if they're symptomatic or have stones with the polyp, you just take out the gallbladder. Most common cause of Barrett's esophagus. Good, GERD. Again, if you see tobacco or smoking cessation on the test, it's probably the answer choice 95% of the time, but not here. GERD increases your likelihood of Barrett's esophagus or cancer by odds ratio of about 8. Tobacco and alcohol are both a little bit less than 2. Statistical tests used to compare the association between 2 qualitative variables, categorical variables, because that's going to be a chi-square test. Right? If it's quantitative or numbers, and 2, you could do a paired t-test. Linear regressions just look how you can predict other variables based on other variables. All right, virus associated with this clinical exam finding. Good. This is condyloma, acuminata, and HPV. Excellent. Sometimes they'll ask different types, right? Benign versus more malignant. In general, 6 and 11 are the most common, and benign, the higher you go, 16 and 18 would be more malignant. Best way to measure distance from anal verge. Rigid proctoscopy, flex sig, or MRI. It is rigid because it's a fixed length, right? Good. Next step in management, a 50-year-old male, history of Hep B, found to have a 2-centimeter solid liver mass in segment 3, and AFP of 725. Maybe hint that's high. Good, segmental resection. You do not have to biopsy it. If the imaging is concordant with the history and you have an AFP greater than 400, that is a diagnosis of hepatocellular carcinoma, and you can just resect. All right, breast mass excision with LCIS and positive margins. Good, tamoxifen and risk modification. Becomes very different if it's DCIS. Histological stain used to identify melanoma. Good. It would be S100. HMB 45 would be another alternative. Most common organism associated with sepsis in an asplenic patient. Staph aureus is not an encapsulated organism, so specifically related to asplenia, strep pneumoniae is their most common cause. All right, breast biopsy pathology reveals multiple long spicules and central areas of lucency. This is a radial scar and relatively benign, and this is on Dr. Dixon Whitmer's extra review sheet. All right, let's check in again. We're halfway there. 50 questions done, 50 questions left. Suspense is killing it. We have an unnamed. You have to look them up on the roster, but okay, still competitive. Still got room. Let's see. Factor deficiency associated with bleeding complication in patient with Christmas disease. Christmas disease is hemophilia B, right? And that's going to be factor 9. Hemophilia A, factor 8, that would be type 1. Number 3 is factor 12, and that's Hageman deficiency. What's the appropriate T staging for gallbladder carcinoma that invades the lamina propria? So lamina propria is T1A, muscularis would be T1B. Review that again tomorrow in our hepatobiliary lecture. Abdominal wall nerves run between these two structures. Good. Internal oblique and transversalis abdominis. One way they could ask this is, where do you want to do kind of your tap blocks, right, for your abdominal procedures and hernias? Make the diagnosis: dermatitis, dementia, and diarrhea. That is going to be niacin deficiency, also known as pellagra. Niacin is also vitamin B3, so you can think of the 3 related with that. Most common complication of a popliteal aneurysm. That's going to be thromboembolism. Good. Also a risk of other concomitant aneurysms, so you have to look. But the most common complication is flicking off little clots distal. Gene mutation associated with thyroid cancer arising from parafollicular C cells. This too is medullary thyroid cancer associated with the RET mutation or MEN2 syndromes. Menin is related to your MEN1 syndrome. Anyone know what PRAD1 mutation associated with? Also in the neck. Parathyroid carcinoma. Next step in management: a 72-year-old diabetic female with palpable dorsalis pedis pulse and a wound to the dorsum of foot. Good. Just to brief me, you have palpable pulses, you're getting blood flow there. Option number 2 is related to claudication, and there's not much with a palpable pulse that you're going to be able to improve on an angiogram, besides increasing your RVUs. First line treatment for fungal peritonitis related to peritoneal dialysis. Good. That is removal of dialysis catheter. So different if it's bacterial, right? Bacterial, you can try to treat through with IV antibiotics and installations of antibiotics through your PD cath. But unfortunately, if it's fungal, it's got to come out. Lower leg compartment associated with foot drop when compromised. It's also the earliest and most frequently involved compartment. That's going to be anterior. What would you do here? Next step in management, potassium 6.8. And the nurse hands you this EKG strip. Can't consult cardiology. Those are peaked T waves, and you want to stabilize your cardiac enzyme with calcium chloride. Good. Then you could treat it with other things. Make the diagnosis: seizure, status post-aggressive crystalloid resuscitation, and surgery for perforated peptic ulcer disease. Ooh. Okay. So again, relating back to the question stem, hypocalcemia is usually related to massive transfusion of blood products, right, from the citrate. But they're telling you aggressive crystalloid resuscitation. Crystalloids, both LR and obviously to a higher degree, normal saline is going to be high in sodium and chloride. It's the hypernatremia, not hyponatremia, that causes the seizures. Mechanism of action for antibiotic treatment of choice in managing entamoeba histolytica liver abscess. So antibiotic of choice is going to be Flagyl, and there you go. Choice number 3 is that mechanism of action. Most common nutritional deficiency after gastric bypass procedure. Iron. Surgical management: 1 centimeter carcinoid located 5 centimeters proximal to the pylorus. It's going to kind of be an inverse of our last one, right? It's a carcinoid, so you don't need wide margins, right? Like just like the appendectomy. So a simple wedge resection. Carcinoid or a GIST tumor of the stomach, you just need kind of negative margin. So a wedge resection would be fine. You don't need 5 centimeters. And obviously a total gastrectomy would be a little aggressive there. Indication for surgery in asymptomatic primary hyperparathyroidism. Good. Bone density, T-score, osteopenia, less than 2.8. Good. We'll go through all these tomorrow in our endocrine lecture as well. Femoral hernia technique after reduction of incarcerated bowel. Right, McVeigh, so conjoined tendon down to Cooper's ligament. Good. If you're trying to do a tissue repair after bowels stuck in that femoral hernia. All right, next step in management here. Hypotensive patient, status post Hartman's, cardiac output's 5.5, and your stroke volume variance is 20%. Just talked about this in our last lecture. Good. Crystalloid bolus. So stroke volume variance greater than 13 or 15%, depending on what you're using, is indicative of hypovolemia, right? So you're going to need to fill the tank with more crystalloids. Adjunctive hemostatic therapy for uremic-related bleeding. Good. DDAVP, also in our last lecture. Excellent. Ventilator strategy for treatment of ARDS. Good. Tidal volume of 6. Low tidal volumes anywhere from 4 to 8. But I'd say 4 to 6 is probably going to be the range that they give you on ABSITE or written boards. You want to keep your plateau pressure less than 30 and go as high as you want on the PEEP. But obviously your plateau pressure will limit you there. Make the diagnosis: a liver lesion on MRI with central stellate scar and uptake of sulfur colloid on technetium scan. That is focal nodular hyperplasia. It's those Kupffer cells, right, that uptake your sulfur colloid. Whereas in an hepatic adenoma, you lack those Kupffer cells, so it's going to be negative. Characteristic of CT imaging concerning for adrenal malignancy. rapid contrast washout is actually a good thing, and kind of fatty tissues or low density attenuation is a good thing. Calcifications in the adrenals is a bad thing. Drug of choice for treatment of aspergillosis. Good, voriconazole for aspergillosis. Amphotericin B is going to be used for mucor, which shouldn't really show up on your exam. All right, structure located anteriorly within the renal hilum. That is going to be the vein. So it goes vein, artery, pelvis. Good. What are you going to do? Hypotensive trauma patient after car accident, GCS3, intubated, blown right pupil, wide mediastinum, and positive abdominal fast for free fluid. A lot going on. But stop the bleeding first. So laparotomy, stop the bleeding, avoid any further hypotension or hypoxia. Then you can deal with the brain and everything else after. A statistical test to compare curriculum effect on ABSITE scores at 4 different institutions. All right, more than 2 quantitative, we're going to need an ANOVA for this. Good, majority, you got it. All right, that's through 75. Let's check in with the board. At this point, it's still unnamed user. It is still unnamed user. They dominating. All right, I'll have to look at the course roster afterwards. All right. Chief Dr. John's on the board at position number 8, but being outdone by his own PGY2, just saying. All right, last 25. Let's go. Coronary vessel that determines the circulatory dominance as it branches from right coronary or circumflex. All right, that's going to be your PDA. Greatest stimulus for angiogenesis during wound healing. Hypoxia. All right, number of days recommended to hold rivaroxaban prior to elective major surgery. Also known as Xarelto. Oh, it's 2. So best available answer choice. So this is pretty much institutionally specific. There are a few national guidelines, but even those are wishy-washy. Most people for these new 10A inhibitors are going to say hold it for 2 to 3 days. 2 is probably the most common number across the board. 5 is going to be related to Coumadin. You want to hold Coumadin 5 days before. And 7 is going to be Plavix, one of those major antiplatelets. Pulmonary function testing appropriate for pneumonectomy. Okay, FEV1 greater than 2 is excellent. You want that DLCO to be greater than 40%, borderline maybe 30. Everything else is just low. Again, just basic test taking strategies. You really don't want anything low if you're trying to tease out what a minimal threshold should be for a surgery. Make the diagnosis: glossitis, anemia, weight loss, and a left femoral vein thrombosis. That is a glucagonoma. Excellent. Treatment of a persistent pancreatic leak, status post recent splenectomy. You could do a distal pancreatectomy. It's just a little aggressive. Probably treat with ERCP and stent first, right? And try to internalize that drainage. First sign of blood transfusion reaction in the operating room. Oh, so on the floor, it is fever. Problem is, fever in operating room is hard to diagnose, right? Because they're exposed, relatively hypothermic, although you're trying to maintain normothermia. It's actually the first thing you'll see in the operating room is bleeding. And again, rash, also a difficult one because you have everything prepped and draped. So on the floor, anywhere else, it's going to be fever. In the OR specifically, we're looking for bleeding. All right, next step in management, a 40-year-old female with fever and painful neck goiter after a recent upper respiratory infection. It's not COVID. NSAIDs, right? This is subacute thyroiditis, decorvains thyroiditis, etc. You want to treat that with NSAIDs. What's the syndrome of polyposis and mucocutaneous pigmentation? It's going to be Peutz-Jeghers syndrome. Gardner syndrome, it's kind of a variant of FAP, but usually you have bone lesions more commonly located on the skull. And Turcotte's is also polyposis, but with brain tumors itself, not just bony masses. Initial workup of a 4-centimeter adrenal mass found incidentally on a patient admitted post-op day 1 after a car accident with TBI and a femur fracture. Dope. You want to wait and follow up in 3 months. Yes, you want to work up a functional incidental adrenal mass, but what's the problem of checking a cortisol and catecholamines on post-op day 1 after severe trauma, right? They're going to be elevated and potentially artificially so. So you want to wait at least 3 months. Ventilatory management of elevated peak airway pressures. The easiest thing to do is going to decrease your tidal volume. All right, reversal agent used for life-threatening hemorrhage related to the use of medication inhibiting carboxylation of glutamic acid. Fancy way of saying, how do we reverse Coumadin, right? PCC, prothrombin complex concentrate. Indexnet alpha is going to be your FDA approved reversal agent for rivaroxaban, Xarelto, and Eliquis. Idaruximab, that's going to be Pradaxa reversal agent. And again, a lot of your institutions may use Kcentra or PCC for reversal of Xarelto, but it's not FDA indicated. And on ABSITE and on your boards, they can't give you a choice that's not FDA indicated. Okay, so don't always fall into the trap of what we do here at my institution or how I was trained. It does have to be an FDA indication. Treatment for persistent jaundice and anemia in a patient with hereditary spherocytosis. Good, splenectomy. Sometimes you'll occasionally do a cholecystectomy with it, but the main objective here is take out the spleen. Most sensitive test for recurrent thyroid cancer after a total thyroidectomy and iodine radiation. Right, thyroglobulin. Calcitonin is for recurrence specifically of medullary thyroid cancer, and TSH you monitor just for your synthroid dosing, but for cancer recurrence, you're going to monitor your thyroglobulin. Make the diagnosis: pancreatic cyst with the central starburst calcification, low CEA in the fluid, and no mucin. Good, serocystadenoma. Cytokine that stimulates B cells to become plasma cells. That is IL-4. B4 is how I remember. IL-8 is cleanup, and IL-8 and chemotaxis. We'll go over all this stuff in the kind of basic science portion of potpourri tomorrow. Most common cause of late arteriovenous fistula failure. Good, that's venous neointimal hyperplasia. Good. Topical burn wound treatment associated with hyponatremia. Good, Hyponatremia is going to be silver nitrate, silver sulfadiazine related to neutropenia. And then mafenide starts with an M, metabolic acidosis. All right, next step in management here, 60-year-old male, 2-centimeter bilateral adrenal nodules and plasma urine catecholamines. Ooh, adrenal vein sampling. So you may have to go to adrenal vein sampling, but first you want to do more of a non-invasive test first. So your serum and urine workup of FeO is positive. Then you want to confirm it with an imaging test, usually an MIBG scan. And there's two different isotopes there. I think it's 123 and 131, if I remember off the top of my head. If that's inconclusive to what side your FeO is on, or if they both light up, then you could do an adrenal vein sampling to target which side it's really coming from. Or it may be bilateral. It's rare, but it could be bilateral. Treatment of choice for end-stage renal disease patient who has DVT and developed heparin-induced thrombocytopenia. Good. The gold standard is argatroban. You will occasionally see them use fondaparinux, but again, it's not truly FDA indicated in the treatment of HIT, so not a viable answer choice here. And by valirudin, you would use if this patient had hepatic failure, right? The recommended margins of excision for melanoma with 2.6 millimeter depth. Good, 2 centimeters. Don't need anything more than that. Most common malignancy after a renal transplant. Good, squamous cell carcinoma. And most common cancer outside of skin cancers is lung adenocarcinoma. Next step in management, a 52-year-old male presents with hoarseness and a 5-centimeter right neck mass. FNA is positive for follicular cells. Nope. So you are probably going to have to do a thyroid and probably a total thyroid based on the size of it. We'll talk about this tomorrow. But if preoperatively they have indications for local invasion of a hoarse voice or previous neck surgeries, you're indicated to do laryngoscopy beforehand to prove that there's not already injury or invasion of your recurrent laryngeal nerve before you go into the neck, and the patient and the lawyers blame you for injury to the recurrent. Most common complication of platinum-based chemotherapy associated with colorectal cancer treatment. So most commonly, this is going to be FOLFOX. That platinum base is based on that oxaplatin. Oxaplatin, the side effect is peripheral neuropathy. Last one, intestinal hematomatous polyps, skin tumors, breast carcinoma, follicular thyroid cancer, and a P10 mutation. Good, Cowden syndrome. All right, let's see. Results are in. The minions are calculating it. Just gonna walk away, being our first day's ABSITE HQ champion. I'll be praying for the thickness, and if you lose, boo-hoo. Hey, look, I made it. It is our unnamed surgical resident. I'll have to go back and reverse look you up. But I will find you. I will give you credit, and I will email you an Amazon gift. Listen, I hope everyone had fun. I hope everyone learned something. We're only halfway through. We got a whole nother day tomorrow. Packed a more high yield ABSITE review. But if nothing else, I wanted to hopefully show you that there is more fun and engaging ways to do ABSITE review. And you all literally just did a mock ABSITE review, right? We all just literally went through 100 questions. There's no difference really between that game and your real ABSITE. Question stems may be 1 or 2 sentences longer, but that's just eliminating the fluff. And there may be 2 more distractors, but you can always get it down to 3. ABSITE's a game. Congratulations. Thank you all for playing the game, and we'll see you all tomorrow.